All right, g'day. Welcome to the WA Country Health Service ultrasound training module. And this is a big step back. This is sort of a look at ultrasound skills development, and I'm going to demonstrate this through a number of cases. So when you're learning ultrasound, there's obviously a pathway that you follow. There's a journey that you go on from learning how to do the basics, becoming more advanced. And the idea of this talk is to sort of explain that, but put it into the context of some cases so that you can see how that changes over time. Now, we've talked about this before, but there are three main sort of ways that you need to improve your ultrasound skills. Number one is learning hand skills, so learning how to drive the probe, manipulate the machine so that you can get the picture on the screen. Obviously, that is fundamental to ultrasound, and we teach this through lots of hands-on practice. You can do this on your own a lot, so you can do a lot of your own hands-on learning skills, but this is much faster if you've got someone who knows what they're doing standing beside you, looking over your shoulder, giving you tips on how to optimize your images, because it can be very frustrating at times trying to find small things particularly, and doing complex moves such as echoes without someone guiding you. You can spend a lot of time with the wrong images and not knowing how to correct that. As you get better, you can self-correct, but when you're starting out, it's great to have someone looking over your shoulder. And this is what a lot of hands-on workshops are good for, is getting that exposure to teachers. And our SEEDs, our sonographic educators, are really good at teaching this stuff. The second part of this is learning eye skills. And what eye skills is all about recognizing the pictures when you see them on the screen. So pattern recognition, learning how to look and what to look for, and obviously being able to optimize your images by changing the gain and the depth and the frequency so that your eyes are seeing what they need to see. Probably the most crucial part of all this, though, are the brain skills. And brain skills are essentially about learning what it is that you need to be looking for. So learning how to recognize abnormal from normal. And that requires a lot of exposure to a lot of images, a lot of deliberate practice. And over time, you get better and better at this. But the old adage is that you can't see what you do not know. So if you don't know what something looks like, even if you get a perfect picture of it on a screen, you're not going to recognize it, and so you won't make that call. The other thing about brain skills that we try and teach in this course, and I really can't say this is the most important thing, is being able to apply the pictures and the information, the data that you're getting from your ultrasound to the clinical context, whether that's the individual patient context and what their symptoms are, but also in the geographic context of where you are. So diagnosing something like a testicular torsion means a very different thing if you're in a tertiary hospital versus if you're in a remote clinic that is many hours from a surgeon. So you need to understand what it is that you're going to do with that data when you do try and answer these questions. Quick psychological quiz. I'm going to describe an animal that has 4 legs, can run very fast, eats grass, and has a mane on the back of its neck. Just take a moment to think about what that animal may be. Now, if I asked you this and you work in Australia, you should be thinking a horse, I would imagine. But if I were to give you a bit of context and say that we're now standing in Africa, obviously the differential diagnosis becomes much different. And then if I were to show you this pattern, you would recognize that this is a zebra straight away. So the point of this is that our understanding of what we see is based on pattern recognition and context. So always remember that we're thinking about the context that we're in, and we're trying to look for patterns that sort of help us make the diagnosis. In terms of the evolution of your skills, there's sort of 4 main areas that I think that we need to evolve our ultrasound skills. And I think the procedural aspects of ultrasound, which for most doctors will be using an ultrasound to guide a needle to a target, whether that's a blood vessel to put a drip or an outline in, or if you're trying to do a nerve block, for example, being able to safely track a needle through the tissue to a target is really a fundamental ultrasound skill. And it requires a lot of hand skills, and it requires an understanding of the geometry of what we're doing, and is a really crucial part of learning how to do ultrasound. And it's probably a very high yield in terms of making sure that you can do the best by your patient, get that line in when you need to, or provide quick pain relief, for example, with a nerve block. So I think that is a fundamental skill which we should all try and acquire early on in our ultrasound journey. Now, most of what we have traditionally been taught in point of care ultrasound is this binary ultrasound style where we're trying to sort goats from sheep. And the FAST exam is a great example of this. So we're not trying to make a diagnosis, we're just trying to say yes or no to clinical question. Is there fluid here? Is there fluid there? And that is what's been taught for a long time. And I think that that's a very robust way of doing ultrasound. These protocols are developed so that you don't make errors, to make it as simple as possible. But I think for most senior doctors working in WA Country Health, we can go a little bit further and can be a little bit more nuanced. And in order to move from POCUS to a more comprehensive ultrasound, you have to go through this discipline of following protocols. Most POCUS protocols are very simple. It's 3 or 4 steps, like looking in the different quadrants or doing an echo, just looking at the different views. But once you become a little bit more proficient, you can start integrating some clinical information. And a good example of this would be a patient with right-sided abdominal pain, which is very common. I see this 3 or 4 times a day in the emergency department. And you could say, I'm going to look at the liver, I'm going to look at the gallbladder, I'm going to look at the kidney, look for appendix. But if you have a protocol in your mind where instead of just looking for one of those, if you systematically go through these different things, then you get much better likelihood of picking up the problem, and over time you get better at scanning and looking at these things as well. Now obviously that's a big step up from just saying yes or no there's a gallstone up to making more subtle diagnoses, and looking for appendixes can be really tricky. So I don't suspect that most people will get to that point, but that is sort of the target, is to sort of head for that protocol, robust, clinically integrated ultrasound. And comprehensive ultrasound is what happens over in the MIT. This is what we do in our suite at Charlie's ED, where we do spend a lot of time with patients, going through doing complex protocols, looking at all the different organs, measuring everything, and trying to really make a firm diagnosis, and actually excluding a lot of diagnoses as well, which is tricky to do if you're doing this as part of a simple POCUS. POCUS is better for ruling in, it's more sensitive, but not very specific. And so ruling things out is very tricky with point of care ultrasound. So that's what we try and do with more comprehensive ultrasound. But I think to get to that level, you need to basically, if that's where you want to go, you need to bite the bullet and do some formal training in ultrasound, which is not going to be quick. All right, let's go through some cases to illustrate some of what I'm trying to point out here. So this is a FAST study. This is a transverse view of a pelvis in a young trauma patient. And I think most people would be very happy to say that is definitely positive. There's a large amount of black, swirly, echogenic grey blood floating around in the pelvis and the bowel loops floating within it. So it's a clear positive. That's not difficult. This is what FAST is all about, just putting the probe on, looking in the different areas and saying yes or no. Blood can be tricky to pick, but I think even the most novice scanners would pick that that's abnormal. This is the same patient. If you're a little bit more adept, we don't ask you to look within the organs when we do FAST studies. We're just really looking for free fluid. But if you are a little bit more adept, you can look at the spleen and you can say, well, that's actually abnormal. There's a contained hematoma within the capsule of the spleen there. This is most likely the source of this patient's bleeding. And sure, depending on the context, depending on what the patient looks like, you probably need to move on to either theatre or to a CAT scan. But this is a useful piece of information to help you guide what's going to happen next. Then this is the same patient. This is their right upper quadrant. And if you're a POCUS provider and you're just answering that yes or no question, it's clearly yes, there's blood in Morrison's pouch. There's no doubt about it. Nice big black triangle of blood there. But there's also some blood sitting in the perinephric space, which I think a lot of binary decision-making ultrasound providers might miss, that there's that bit of blood in the inferior pole of the kidney there, and that's probably useful information. It might not make a big difference to this particular patient, but it would be very easy to miss that if you didn't have the blood in front and think of that as just something else, and miss the fact that this is actually blood in a different compartment, which may require a different intervention, a different specialist, more information, for example. Let's talk about gallbladders. I've got a number of gallbladder images we're going to go through. This first one is a very straightforward. Gallbladders are easy to find usually. They're quite big, they're black, and they usually sit pretty superficial, so in most people with a bit of technique you can find them. And gallstones, large ones like this, are very easy to spot. So the POCUS idea, yes or no, yes, there's a gallbladder, definitely has a gallstone in it. Slam dunk diagnosis, cholelithiasis, done. But you have to put this into the context of what the patient's presenting complaint is. If they're here with epigastric pain, I would be reluctant to say that this was the cause of the patient's epigastric pain, because that stone looks like it's not really causing any trouble, it's just floating around in the gallbladder. And so it can be very seductive in ultrasound to find something and then pin all of the patient's symptoms to that. And having that discipline of saying, well, actually, no, I don't think it is the sort of the next level that we are hoping to get you to. Here's another gallbladder picture. Let's just scroll through this one. It's a nice little clip. And we'll play that a few times. But there's a gallbladder. It's got lots of this echogenic sludge material. There's a few little small solid stones up here around the fundus that do cast a shadow. And the really important thing on this study is not all of that sludge. The really important thing is this thing right here. So there's a large stone lodged right in the neck of the gallbladder with a hard shadow behind it. So this is a really important point, that if you just looked at this, as most of us do when we look at gallbladders, you might miss the fact that this is the problem, this is the culprit stone down here. So having the discipline of stopping and really taking the time to focus in on the neck of the gallbladder is really crucial, because if you've got a patient that looks sick and you're worried about this phenomenon, it's easy to miss if you don't spend that extra couple of minutes lining up the neck of the gallbladder. May have to use different windows, different views, deep breath holding, go through all the different tricks and tips to try and work out whether this is the problem or not, because that makes a big difference to this particular patient's journey. Here's another gallbladder. This one can be quite subtle, so a lot of people I show this image to don't actually recognize that this is the gallbladder, but it is. So there's the liver on the left of screen, and if you look there, there's the gallbladder, and it's quite distended, so it's about 5 centimeters across on the measurement. And then a lot of people also miss the stones. There's a stone with a shadow sitting there down in the neck of the gallbladder. And so this can be really subtle. And so the point of this is that if you haven't looked at lots of gallbladders and you've never seen a gallbladder that's full of sludge and pus that is sort of almost isoechoic with the tissue around it, it'll be very easy to miss this as a problem and not recognize that that's a gallstone, because it doesn't really look like a gallstone out of context of not seeing the rest of the gallbladder clearly. So that's the sludge and pus. There's the gallstone. And then next level, there is actually a little micro perforation there on the front wall of the gallbladder, which is very difficult to appreciate, but can make a big difference to what happens with this patient next as well. We'll stay on gallstones for a minute. So this is a clip through the common bile duct, and I'll just play the clip through. And I think we'll pause it there. So it's very easy to miss these. So this is a stone in the common bile duct with a very distended common bile duct. There's also quite good going intrahepatic biliary dilatation as well, which you can see in the lobe of the liver there. So this is a really important point, that applying the clinical information is crucial. So if this patient presents with jaundice, pain, looks like cholangitis, their LFTs are off, their bilirubin's high, you know that there's something obstructing. And when we look at the studies of even expert scanners that have done 10,000 scans, they're not perfect. They miss these stones about 1 in 5. So their sensitivity tends to be up in the high 80s. I think that my own personal sensitivity is nowhere near that. And I think for novice scanners, it's probably more like 30 or 40% that you're going to pick these, because they can be very subtle, and often they're not as clear as this one. They're often further down and sort of hidden behind the gas within the duodenum. So these can be tricky to spot. And so I think you have to accept that we're imperfect, and that as you learn ultrasound, you're less perfect, and you get better as you go on. But you have to accept that if the clinical context says that this is an obstructed liver, everything else looks like an obstructed liver, you can see the big CVD, don't have that pride where you say, I can't see a stone, therefore there's not one there. You need to accept that everyone's imperfect and move on to the next thing. So this patient needs to go and get that stone removed. They need an ERCP or an MRCP at the least. So you need to move on with your study to the next modality, whatever it happens to be. So having that pride and swallowing it and accepting that we're all imperfect is really, really important. And one more gallbladder. This one, I'll just play this clip through. It looks pretty similar to the first one or the second gallbladder that we saw. So there's a gallbladder. It's got this sort of echogenic material within the gallbladder. And we're very easy to go, oh, that looks like sludge. There's a bit of a funny looking liver. It looks a bit heterogeneous and ragged as well. And I'll show you the next picture. This is the transverse view of that same gallbladder. And you can see that this sludge actually goes around to the anterior wall on the roof of the gallbladder, which doesn't sort of make sense because sludge should be dependent. And when you put color flow on it, it's got flow within it. So this isn't sludge. This is a tumor. This is a cholangiocarcinoma. Now, do you need to know that? You definitely don't need to know that as a point of care provider, but you do need to be able to recognize that something's abnormal and that this is no longer in your comfort zone and move on to the next modality. So being able to recognize what's normal, what's abnormal. You may never see this again in your career as a point of care provider, but you just need to be able to know that you're seeing something that's wildly abnormal and that this is no longer in the realm of point of care ultrasound. So they need a formal scan as soon as possible, or a CT or something else to sort of move this patient ahead, because spending time looking at this is not going to help you at the point of care level. I'm going to talk a bit about eyeballs. Eyeballs are interesting because, yes, it's a very easy scan to do. Technically not challenging at all. Eyeballs are very superficial. You get great pictures of them. But just knowing what to do with the information is really important. So this is a picture of a lens dislocation. Now, it's pretty obvious when I say that that's a lens that's not in the right place, it's dislocated. But if you haven't looked at a lot of eyeballs and you've not looked at a lot of lenses, you wouldn't recognize that lens is not quite in the right place. You might miss that. So a patient presenting with sudden visual loss, or in this case, it was actually a patient who had really dense cataracts who had actually an improvement in their vision when their lens became dislocated. That's tricky. So you need to have that mental bank of images of what a normal eye looks like, where the lens usually sits, what it looks like on ultrasound, so that you can then recognize when it's not quite right. So this one's just been displaced off to the side. This is a video loop demonstrating a retinal detachment. That's pretty obvious. I think most of us would find that very simple to call that a retinal detachment. So there's a nice thick hyperechoic membrane there that's floating. It's got blood vessels in it even, and it's fixed at the optic nerve root. So that is definitely a retinal detachment. It's an ophthalmological emergency. They need to get to an ophthalmologist. So if you see that, you know what it is. That's a pretty good diagnosis. High fives all around. Having said that, these can be quite subtle, and this is not a lens dislocation. But when I was starting to learn eyeball ultrasounds, I'd see these things in the back of the eye, and I would turn the gain up, and this is clearly a very overgained ultrasound of an eye, and you can see these sort of subtle films floating in the back of the eye, and this is a vitreous detachment. And obviously this is also needs to have an ophthalmologist have a look at it, but not today. Like, this is one that can wait. And what I learned over time is every eye I looked at, it seemed in middle-aged people, if I turned the gain up enough on the ultrasound machine, I could make everyone have a vitreous detachment or an intravitreal hemorrhage, because there's often a little bit of that going on. And if you crank the gain up on the ultrasound, you can see more and more of this stuff. And obviously the ophthalmologists are not going to enjoy it if you refer every single patient that has anything in their posterior chamber. So understanding the clinical context and understanding what's normal and what's abnormal and what sort of even shades of grey of normal is really important. So be aware of this. Look at lots of eyeballs, but just be aware that there's a lot of this asymptomatic stuff floating around, which you need to be aware of when you're doing ultrasound. This is a really good case just to demonstrate how you sometimes need to think outside the box with ultrasound and maybe recognize when you need to move on to the next modality as well. So this was a case of a woman that had quite horrible chronic menorrhagia and presented to the emergency department with a hemoglobin of 21, and she was actually reasonably well. Like, she was a bit short of breath and maybe a little bit dizzy at times, but she was young and had been coping quite well with this, despite being quite biochemically unwell. And she had obviously had a lot of menorrhagia, and so we had a look at her uterus, and we'll just play the clip through. Sorry, it's a bit grainy, this one, but she clearly has a large, heterogeneous, bulky, fibroid-laden uterus, so we were pretty happy that that was what the source of the menorrhagia was, and she was likely going to need some sort of surgical fix for her menorrhagia, and we could transfuse her and do all the other stuff, but the gynecologists were keen to get her into theatre and do a hysteroscopy and possibly do an ablation. So this was one where we were saying, oh, that seems like a reasonable thing to do. There's one thing that I noticed when I was looking at this study, is that if you follow this very carefully and have a look just up here at the top, this is bowel, and there's some acidic fluid outlining the bowel, just there behind the bladder and in front of the uterus. And that's sort of interesting. So ascites didn't sort of fit with the picture. She had no other reason for having ascites. And as far as we knew, her liver was normal. She was relatively young and healthy otherwise. And we thought, oh, that's a bit odd. So what could be causing this? So being keen sonographers, we started looking further, and this is her parasternal long axis view. And if you look at this heart, in first view, you can look at this parasternal and go, oh, it's beating away there. It's not markedly abnormal, but given the context of someone that's dramatically anemic, you would expect a heart to be going like the clappers. It should be hyperdynamic, but it isn't. It's hypokinetic, if anything, sort of globally down. And that mitral valve's not really opening as much as I would expect for an otherwise young person. So we put some colour on. I'll just play this clip through. If you look at this, you can see that there's a little jet of aortic regurgitation and a jet of mitral regurgitation down the back here, and this mitral valve is not looking very happy. So this is a young woman that unfortunately has undiagnosed rheumatic heart disease and has probably got some long-standing cardiac dysfunction, as well as in this severe chronic anemia, which can cause a cardiomyopathy of its own. So this was one where we had to sort of put the probe down and say, well, actually, this isn't someone I want to rush off to theatre. This is someone that needs a bit more thought and a bit more workup before we decide what the best possible course of action is. This is an apical 4-chamber view, and on this view it's much more obvious that hypokinesis of the left ventricle, massive left atrium. This is a chronic process that's been going on for some time, and this is something that can wait a little bit longer to get sorted out. So we can give her slow transfusion, we can try and get a hemoglobin a bit better, but I don't think rushing at a theatre is the best thing for this patient right now. Another echo, just to show the decision-making that goes around ultrasound. So this was a dialysis patient who had missed a lot of dialysis due to one reason or another and had presented with shortness of breath, and we'd managed to get him in for dialysis, and he'd gone off and had dialysis but hadn't really improved as much as we would like. And then when we had a look at his heart on his echocardiogram, you can see here, this is the parasternal long axis view. It's got LV here, which is quite hyperkinetic and hypertrophic as well. And you can see there's a large pericardial effusion going all the way from the back of the heart here. This is the bright white pericardium, all the way around to the front of the heart. And if you look on some other views of his heart, you can see that this pericardial effusion's actually got all these sort of fibrin strands floating in it. It's not a nice black pericardial effusion. This is quite complex and has lots of bits in it. And if you're a pattern recognition sort of person and you've looked at this before, you'd realize that this is very typically what uremic pericarditis looks like. They have these complex fibrin strands within their effusions. And then the question is, so this person's short of breath, they have a large effusion. Should we tap the effusion? Would this actually help the patient if we tap the effusion? And I think maybe 5 years ago I would have gone, well, yeah, they've got a big effusion that's squashing their heart. They need to get that done. But once you learn more about the subtle findings of tamponade on echo, you can see that this patient doesn't really have any signs of tamponade. Maybe very subtle, but certainly very borderline. There's not much RV or RA collapse, and we actually did mitral valve flows, and there wasn't really any change whatsoever. So we thought that tapping this heart was probably not the right thing to do. One, there's a risk involved, and we didn't think it was actually going to improve this patient's lot. And more importantly, I was happy to sit on this patient and maybe transfer him to a bigger tertiary centre to get some formal cardiac workup, because this didn't need to happen right away today. And I think one of the problems with learning ultrasound is you can see this sometimes quite dramatic pathology and have that reflex that you need to do something about it, when sometimes the right thing to do is to look a bit further, look a bit harder, and make those more subtle calls. And certainly using ultrasound to decrease what you do is not common in medicine. We tend to use it to increase our interventions, and this was a case where we went in the opposite direction. This is a nasty diabetic foot infection, and this is a case that really demonstrates that concept of active pattern recognition. So this is a patient that was very septic and unwell with a nasty sore over the ball of their foot with diabetes. And this is a still image of the foot. You can see there's clearly a collection there under the skin. Looks like it goes down to the deep muscle layer. And sure, the patient may need drainage maybe today, maybe tomorrow. We ran the video loop through this collection. And if you look here, I'll just pause it there. So this is actually, this black bit at the top's the thick callous skin on the sole of the foot, and this tract coming through here is actually the pus swirling in and out of the collection. So you can see as we apply probe pressure, we can actually move that pus up and down that tract into this deeper cavity. And you could stop there and say, yep, well, that's clearly an abscess. The patient needs antibiotics, they need to get their foot drained. But this patient's pretty septic, and the question is, do they need to go to theatre and have this debrided to sort it out what's going on? And the thing that I want you to look at here, just a bit of swirling there, and then if we just pause it, just coming up here, see all these little white things sitting in here? These are little air bubbles or gas bubbles sitting within the collection. So this is potentially a necrotic skin infection or a gas-forming organism within the tissues there. And this has a very high mortality, and the fact that this patient's septic suggests to me that they definitely need to have this debrided, because neck fash does not do well without debridement. So we needed to get this patient off to theatre as soon as possible. And I think that ultrasound here was really useful, one, because it accelerated that decision making. And the reason I put this case to you guys is just so that you need to train your brain to look for these things. If you weren't actively looking for gas within the tissues, it'd be very easy to miss this. So you just need to get that discipline of actively looking for patterns within your scans. Go back to gallbladders. Here's another gallbladder. This was a patient who was unwell, low blood pressure, and came in and had some pain in their right upper quadrant. And one of our team did an ultrasound and said, oh, look, they've got acalculous cholecystitis. There's no gallstones, but there's a thick-walled gallbladder. And, yep, that seems like a potential diagnosis, and it's certainly one of the differentials. But once you've looked at a lot of gallbladders, you start thinking, that's very symmetrical. This gallbladder is just like, there's this rim of fluid that goes all the way around the gallbladder. It's very symmetrical. And one of my colleagues likes to say that the gallbladder is the eyelids of the abdomen, and that it's the first place that edema turns up for whatever cause. And normally when we see like true obstructive or gallstone-related cholecystitis, it's not so symmetrical. It's usually a bit ragged, the wall looks a bit jagged and lamellated, and it doesn't really look nice and neat like this going all the way around. So this is something that we see when there's another cause of local inflammation or edema. And so you can see this with acute viral hepatitis or pancreatitis even, but the common cause is heart failure. And so this patient had an echocardiogram and clearly has a very grossly abnormal echo with that mitral valve's barely opening. It's got a massive left atrium, big dilated left ventricle, which isn't really moving much at all. So great case where sometimes you see something, and if you only look at one organ, you can stop and give up the ghost. Whereas if you recognize that that's just a gallbladder that's edematous, it makes you think, right, why has that got edema? And then you look further afield and you make the diagnosis. So just being curious is really important sometimes with ultrasound. I think this is probably one of the high yield things that we do with ultrasound in rural areas where we don't have access to x-ray all the time. So pediatric pneumonias can be very satisfying. So I love this picture because it shows the different sort of phases or stages of pneumonia. And you've got a kidney over here on the right of the screen. And then we've got some lung at the base, which is very wet with some B lines coming off of the pleura, and then on the left we have this middle lobe pneumonia, which is quite large. It's multiple centimeters deep, and so that's what a lobar pneumonia looks like on ultrasound. And the adjacent inflamed penumbra of lung tissue usually just looks like B lines, sort of what we see in heart failure, but more focal and just around the consolidation. So over the years, I've trained my brain to recognize this, and we turn the probe and look between the ribs. You can see this sort of almost abscess-looking consolidation within the lung. And if you look at lots of kids with this, you start recognizing there's a gradation from this, which is clear lobar pneumonia, to little subpleural consolidations, which you see with RSV and other viruses, and then completely normal. And so it can be really useful for working out what's going on with kids. And you need to train your eyes. And I think ultrasound's actually more sensitive than X-ray. So this was this kid's X-ray, which, it's clearly abnormal. They've got some right middle lobe consolidation going on there. But often that's not the case with kids, particularly early on in their illness. We tend to find the ultrasound finds these things maybe a day or two before the X-ray shows it up. So it can be really useful if you are confident with lung ultrasound in kids. Once again, not a technically challenging scan to do, but one that can easily get wrong through misinterpretation and not understanding the gradations of abnormality. And lucky last, just to demonstrate that point about pattern recognition, this is a cystic lesion seen in the adnexa of a young woman's pelvis, and if you have not seen this before, you might struggle to understand what's going on here. However, if you've seen a few of these, or even just one or two examples, then you'll recognize this instantly. So this is like recognizing the zebra from its stripes, because this is one thing and can only be one thing, and this is clearly a teratoma. And if you've never seen one before, you wouldn't recognize that, but this is a cyst that's got a hyperechoic fat plug with shadow behind it down there in the middle, and in the main part of the cyst there's this dot dash sign, which is the hairs that grow in the teratomas. And this is, diagnostic. When you see this, nothing else looks like this, and it can only be one thing. And I probably spent many years looking for pregnancies and doing all sorts of ultrasounds. I don't ever remember seeing one when I was learning as a point of care provider. But once I've learned how to recognize these and started looking for them, they can often be more subtle and smaller than this. You start seeing them more and more, and it's not because they're suddenly there, it's because you've suddenly learned how to recognize them. So you can't see what you don't know. So this is why you need to train your brain to recognize these sorts of things. All right, that's the end. I hope that sort of makes sense. Obviously, we're all on a journey. None of us is at the end, and we're all trying to get better and better at what we do. But I think that by that active learning and trying to really think about what your ultrasounds mean and applying good clinical information as well, you can move from being a point-and-shoot sort of binary POCUS provider to doing that more subtle stuff and hopefully doing benefit for your patient. All right, see you later.